my spellings were awful. I even always switched letters. I mean, they were always, switched left to right, and sometimes even inverted. That happens even now. And dictation tests were a nightmare for me. And you know, uh, my school days was really difficult, and I carried this on to my college time also. And what would take people 5 minutes to read would take 40 minutes for me. And in spite of all this, I carried a whole lot of a load of mischief on me. So both mischief and dyslexia together weighed a lot, which would have sunk a battleship into a hard rock. So in spite of all this, I could distinctly feel hand of God hand holding me and walking me through the academy during the time of my academics and also during my professional career. So I dedicate this talk to that hand of God which led me through. So can you permit me to join? I mean, share the screen.
It's already there. I think.
Can you hear that? I mean, can you see the screen?
Yes, Roy.
Right.
Put it on slideshow. It will be full screen.
Yeah. Right. So that is about it. So it's a really thank you, Nati, for having me to speak here to all of you. And sorry that I pulled you out from your families and also from this IPL. Okay, everything for a radiologist started with the invention of X-rays, and that revolutionized the way diseases were diagnosed. And Selva would have told you also the way some diseases were even treated. And radiologists at the time, from most of the time of the previous century, they were relegated to a dark corner room in any hospital, which often was very damp, which was very foul smelling, with a lot of radiographs flying to make it dry. That is how a radiology room was, and radiologists' work was confined mainly to diagnosing radiographs and doing conventional contrast studies. And those who could do this vascular studies were considered very elite, very learned people, very professional people. But something happened to radiology in the latter half of 1980. I mean, when cross-sectional imaging devices surfaced, and a dashingly good-looking guy from Stanley chose to become a radiologist. And since then, there was no looking back for radiology, I guess. And I am confined to doing interventions under CT. When you talk about interventional radiologists, people only think about vascular interventions, but I do my interventions or non-vascular interventions under CT guidance. So a little bit of trivia about CT, the invention of CT. Around 1960, four lads from the port city of Liverpool, England, uh, aspired to become musicians and make a living out of selling the music. And they called themselves the Beatles. And they had a recording contract with a company called EMI. And EMI took the sounds of Beatles across the Atlantic to the US and also to rest of the globe. And they created a global hysteria which was called Beatlemania. And EMI Records made loads and loads of money selling Beatles songs. And this money was very tactfully used in the research of an English physicist by name Hounsfield. Hounsfield combined Röntgen's X-rays and the emerging field of computers and developed a device which could give us a cross-sectional images of the body. And this device was not invented with an intent to guide intervention, but still it helped because of the depiction of cross-sectional anatomy was so good, the radiologists could not resist the idea of sticking in needles looking at these CT images. And to place the needle precisely within the body, you can choose the target from the CT image. You can know from where in the surface of the body you can stick in the needle. But the greatest challenge is the angle of incidence, being able to put in the needle in the required angle of incidence. This carries a lot of risk. And if a person can do this, whole lot of interventional procedures can be done in the CT room. Excuse me. Right. So the commonest procedure that we get to do are biopsies. As you can see here, this is a PET CT of a node, a retroperitoneal node, and that's the aorta. And this is the ureter. And there is a node which is sandwiched between the aorta and the ureter, which we can biopsy that to this amount of precision. And this is a solitary pulmonary nodule that I biopsy. These are regulation procedures which are referred to us for every day. Sometimes we get to do some daredevil biopsies like this. See, here is the SVC, the brachiocephalic vein, and the aorta. And there is a node which is perfectly shaped by all these vital structures. And to hit this node, you can see that I have passed the needle with a medial angulation to push in the needle between the SVC and the aorta, and also gave it a caudal angulation. That is why you see the needle in two different slices. Gave a caudal angulation to hit the uh, node, and this happened to be tuberculosis. And I don't think I will do a daredevil procedure like this anymore. And this is another procedure we do, draining abscesses. This is a post-Whipple's deep-seated collection, which was drained under CT guidance. This was a mediastinal abscess, which was drained and cured by CT-guided drainage. And sometimes we do very novel procedures. This is, we called it tattooing. This is a small little node in the wall of a large bowel after doing a resection for colorectal cancer. And the surgeon wanted to do a biopsy, which was not possible because it was on the wall of the node, wall of the bowel. So what he suggested was, he asked me if I could tattoo it. I put a small needle inside and injected 0.3 ml of methylene blue. So patient was straight taken to laparoscopy, and he could, on laparoscopy, he could easily visualize this nodule. You could pluck it out, and this was just a stitch granuloma. And as Dr. Natarajan said, this was a tumor ablation that I did way back in 2002. This was the first percutaneous tumor ablation done in the country. This is a large adenocarcinoma of the lung. The patient could not be operated upon because of poor lung function. And we put in a needle. This is a radio frequency ablation needle. You put in the needle under CT guidance. We open active electrodes like petals of a flower, and then we send in the radio frequency energy, and we burn the tumor. This is immediately after burning. You can see bubbles within, and this is 5 months later, and this is 8 months later. And this is the lung tumor, malignant lung tumor. This is the benign lung tumor, but locally invasive, called lymphrangioma, which was invading into the mediastinum and choking the large vessels. And you see the patient was intubated, and we did the procedure. He was very sick. By two overlapping positions of microwave ablation were done. And you can see after 10 months, the lesion has already almost completely resolved, and patient went back and joined his work as a constable in West Bengal. And this is a malignant hepatocellular carcinoma, biopsy proven in the right lobe of liver. You can see the avid FDG uptake. This was embolization, trans-arterial chemoembolization. 2 days after this embolization, I did the uh, radio frequency ablation. And this patient lived for 5 years after this procedure. You can see it is completely not taking up any FDG PET. And this patient died due to cirrhosis because of hepatitis. And this is my father, who passed away in 1990. During my medical education, when I was in college in Stanley, very frequently he told me I should be involved in alleviation of pain and I should be treating people's suffering. He kept on telling me this, and when 1985, when I went and told him at the end of 1985 that I want to become a radiologist, I could see the agony on his face, and he asked me one question: how will you treat patients? And sadly, before I started doing this procedures to alleviate pain, he passed away. And little did I know back then, a significant facet, a percentage, a segment of my practice would be management of pain. So this is this is a stellate ganglion block for a patient with. So now I'm going to speak about pain management. Quickly, I'll go through that. This is a patient with Pankos tumor in right upper lobe, which is eroded into the ribs, and the stellate ganglion is present in the anterior aspect of C7 vertebra, the anterior aspect of the transverse process of C7 vertebra, and in front of the neck of the first rib. And you can see we have perfectly put a needle on the place of the stellate ganglion and injected 4 ml of 70% alcohol. And this patient already had Horner's syndrome, so that was not a problem. Usually patients develop Horner's syndrome after stellate ganglion block. And this patient was comfortable till his time of death. I mean, the pain score had significantly come down. So this is a similar patient with a Pankos tumor. We thought of doing a similar procedure, but sadly, in front of his neck, he had an aneurysm. So we could not stick in the needle from the front. So we took a novel angulation and did a posterior lateral approach, and we could do this procedure. This is not described in the textbooks even now. And this is described in textbook, the anterior lateral approach, which the anesthetists usually do by with sonography. So this is about the stellate ganglion block. And this is another interesting block that we do is called the thoracic paravertebral block. Thoracic paravertebral space is a potential space where the side of the vertebra from the D1 to D12 vertebra, and it runs from D1 to D12, and it contains the important nerves like sympathetic ganglion, the intercostal nerves, and the rhymi communicants, and so on and so forth. And this block is done for unilateral torso pain. So it is done in patients with rib fractures, patients with rib metastasis, with pleural pain, contusion lung, and patients with one-sided abdominal pain. And Dr. Suresh would know this, with this block, you can do some surgeries like cholecystectomy and even herniorrhaphy and appendicectomy, I believe. And I have no experience in that. But for chronic pain, I use this. And here is a patient. This is a very high-profile pulmonologist. All of you would have known him. He sadly developed lung cancer, and he was on treatment for lung cancer. He developed a large metastatic lesion in the right lobe of liver. And this was causing excruciating pain because of the stretch of the capsule. And so I suggested to him, we can do a thoracic paravertebral block. He was in so much of pain, he just consented and said, try that. So I put in a needle at the level of D5, D6 vertebra, and injected. He was in bad shape, so I did not want to inject alcohol. Injected triamcinolone acetate, 80 milligrams of triamcinolone acetate with a mixture of bucofensorcaine and lignocaine, and he was quite all right. I mean, he died exactly 3 weeks later, but he was quite comfortable, and he was very happy that I did that procedure for him. And about one more thing about this procedure, when I successfully started doing this procedure, I very triumphantly went and told my brothers that I'm doing a procedure like this, and they just nodded and went away. So I just left it, and maybe a few weeks later, they came and asked me, "You were talking about some procedure. What it is? What is that?" So I explained to them on back of a paper napkin. I drew it and told them where I inject. And they said, my dad used to do this under surface marking. And he used to do the thoracoplasties by doing the, paravertebral block. In fact, the whole world, after they had stopped doing this by blind method because the chances of pneumothorax was very high. But with the CT guidance, we are very precise in doing this procedure. And coming to celiac plexus block, celiac plexus are paired ganglia anterior to the aorta in the vicinity of celiac artery. And this is usually done in patients with excruciating pain due to pancreatitis or due to cancers of the stomach or pancreas. And the usual approach is anterior approach through the stomach. And here we have gone anteriorly, and that is the place of the celiac plexus, anterior to the aorta. And we usually inject alcohol, about 12 ml of 70% alcohol. And this is another patient with the CA head of pancreas who had been stented, who had excruciating pain. So we thought of doing a celiac plexus block, but she had a very distended transverse colon. So we had to take a very acute, anterolateral approach. And patients also benefited from this block. And usually we do the paravertebral block, the celiac plexus block, we had been doing it by anterior approach. But I read that the splanchnic block, this is the splanchnic nerve between the celiac plexus and the sympathetic ganglia. You have a splanchnic nerve going behind the diaphragm. So they say the splanchnic blocks act better than the celiac plexus block. So this is very easy to do under CT guidance. You just have to put a needle in the retrocrural space and inject your alcohol or the steroid. And instead of putting these two needles, we have been very successful in doing this. Instead of putting two needles, I started doing this through the disc. So insert one single needle through the disc and inject the alcohol or the steroid. And we also started using the single anterior approach. So we reach the retrocrural space by anterior approach. And you can see the spread of the injectant there. And next is the nerve root injections. This is a surgical gastroenterologist from Stanley Medical College. This was done more than 10 years ago. He had excruciating upper limb pain, and he was investigated, and they found a disc prolapse. So the neurosurgeon had lined him up for a discectomy, and his daughter's wedding was around the corner. So the radiologist from Stanley brought him to me, and he just wanted to buy time for his daughter's wedding. So he had disc prolapse in two levels, C3, C4, and C4, C5. So we were able to precisely place the needle on the exciting nerve root and inject, steroids and long-acting anesthetic. And it is more than 10 years now. He has not undergone surgery. His pain relief was instantaneous, and he went back to work, and he has not been operated as yet. And this is in the nerve block in the cervical region. This is a nerve root injection in the lumbar region, which is very common. We regularly do this for people with disc prolapse. And whenever I do this, I think of Philip. Philip underwent a very major, multi-level discectomy, and he was left with a neurological deficit, which took him off sports. He was a tennis player, and he just couldn't play tennis anymore. So whenever I do this, I think of that. I only wish that I, he had his problem much later, because many athletes come and they have this injection and go. So this is a nerve root injection in L3, L4, which I did and injected same steroids. And you can see the perfect filling up of the nerve sheath there. And we've done many patients, not one has gone for surgery in this part, thus far. And for this, I have to thank our classmate, Dr. Sukumar, and Dr. Selvalakshmi. As I was waiting for my turn to lecture at Cancer Institute, Sukumar with another person was actually demonstrating trigeminal nerve block on a patient with a cancer patient with trigeminal nerve pain, and he was doing it under fluoroscopy. When I saw that, I thought, why can't we do this under CT scan? So when I went back to Stanley, I took a skull and I did various maneuvers on the skull and just saw if I could see the foramen of ovale. And I marked the foramen of ovale and did the sections, and I could easily find out the foramen of ovale. And when I was confident that I could, target foramen of ovale, this is where God's hand comes in. Within about 10 days of that, a dental surgeon came to me and asked me if anything can be done for trigeminal neuralgia, because he had a patient who had severe trigeminal neuralgia who had been operated for. They did microvascular decompression surgery. You can see that scar there behind the ear, and she was had so much of pain that she was actually contemplating suicide. So, so I took her up, and we put a needle. So you can see the needle on the foramen of ovale there, and injected 1 ml of 70% alcohol after a test injection of xylocaine. So this patient had absolute pain relief. And after that, for about a couple of years, I was doing trigeminal nerve blocks. And after that, I heard that in Cancer Institute, in Apollo Hospital, the radiotherapy department, they have a device called gamma knife. So this is where you can give a very thin pencil beam of radiation precisely into the body. So under CT guidance, so they started doing this, this radiation on this foramen of ovale. And so since then, I've started referring patients for radiation. And this is a patient with osteoid osteoma. It's a very common uh, 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 disorder in young patients, and sometimes I've seen it in even 54-year-olds. And this is a very excruciating intraosseous pain lesion. It is not a malignant lesion. So with CT guidance, we can precisely place the needle inside and ablate that with radio frequency. And here is this in the roof of acetabulum. The patient was seen by all orthopedic surgeons, and all of them said it's a very difficult area to operate upon because a young patient, 14-year-old, and we could precisely hit that under the CT guidance and ablate that. And this is another novel procedure. A patient who she was an 18-year-old female after a road traffic accident, had a shattered left ala of sacrum, sorry, it's a right ala of sacrum, and a diastatic sacroiliac joint. Now, this patient was, the orthopedician wanted to fix that. So instead of doing an open procedure, he thought we can do a closed procedure. So under CT guidance, I could easily pass in a needle across the diastatic joint through the fragmented bones onto the body of S1, and then put a K wire inside, pulled out the needle, and gave the patient to my orthopedic colleague. He could easily pass in cancel a screw over the K wire, and we could fix this percutaneously. What was great was this patient was able to stand the very next day. And this patient was referred by our classmate, Dr. Leonard Punraj. This patient was a retired Air India employee. She was 74 years old, bedridden due to osteoporotic compression fractures in the spine. She had bed sores because she could not move in her bed. Her maid would come, give her food, and then go away. And she just used to crawl to the toilet, and sometimes she even passed in the bed because she passed urine in the bed because she could not go to the toilet. She was in a very bad mental state as well. So this is the procedure that I regularly was doing called vertebroplasty. And now orthopedic spine surgeons do it, but I started doing it here. Pass a needle into the vertebra for osteoporotic compression fracture and inject bone cement. And this patient was up and about in the evening. I did it in the morning. She was able to stand without pain in the evening. And This is a very successful procedure that we can do for this patient with osteoporotic compression fracture or metastatic compression fracture. And this is the patient with metastasis from pancreas in the left ala of sacrum. She had excruciating pain. She could not stand. She used to stand with her leg pulled up, standing only on one leg. She could not lie down or sit. So we did an ablation within the ala of sacrum and then injected the bone cement. And this patient lived for 11 months after this procedure, but she was able to lie down and weight bear on that side of the limb. So there are 18,000 radiologists in India. I recently knew that. And only a handful, 1,500 of us do interventional CT. And out of that, a very few, maybe 40 or so, can target lesions targets less than 1 centimeter in size. Now, so these procedures was not available for everybody. So by God's grace, I was able to invent a device which could help radiologists to place the needle precisely with confidence on very small targets. And the learning curve is very quick. He just has to get trained for about 30 minutes or so. And for this, I got the Indian patent and I've applied for US patent. And this was what Dr. Natarajan was speaking about. I got the Medical Made in India Healthcare Innovation Award in 2017, which will help many radiologists to do these procedures. And I like these words of Mother Teresa. She said, "We ourselves feel that what we are doing is just a drop in the ocean, but the ocean would be less because of that missing drop." So I sincerely think so, and I really thank God for being with me during this professional career, and also thank all my classmates and Dr. Natarajan for this opportunity. Thank you so much.
Whoever has got any questions, actually you can raise your hands by reacting. There is a reaction button on your screen.
All questions are out of portions.
Just ask one by one. I'll just go to the gallery view.
Yeah.
Okay, Jayanti, go ahead. Yeah.
Yeah, Roy, fantastic talk actually. So I feel that you are doing something, very, very important for all humans. Actually, living without pain is the most important thing. To improve the quality of life.
And I believe this thoracic paravertebral block can be done for angina.
Yeah,
very good. So I'll keep in mind. I'll refer cases to you.
Roy, Roy, sorry, just a minute. Roy, can you unshare the screen so that we can see everybody on the gallery?
Oh, one sec. Yeah. How do I do that?
Just go to that wherever share and say unshare.
Where is share? Okay, end show. Yes. I'm just figuring it out. Then just a minute.
Yeah, no problem.
Where I can't find that.
Yeah. Okay, maybe I can do it. I'll.
Yeah, I got it. It's on top. Okay, you do it. Yeah, I got it.
Yes, yeah, that's fine. Okay, yeah, go on, Jayanti.
Yeah. Nothing. I just wanted to appreciate Roy's work, and I'm really happy that I could participate in this session and listen to you, Roy. And this tuberculosis of the spine and people having this severe paraspinal spasm and all that. Do you think that it will be of help, this kind of a pain management?
No, see, the problem is we inject steroids. Okay, so the nerve blocks should not be done in in that kind of pain. And obviously, if they have, even in case if they have a neurotic pain, we will not be able to inject steroids in spondylitis.
Okay.
Even for vertebroplasty, we will not be able to do this even for vertebroplasty because it's contraindicated in infective spondylitis. Hey, Srikanth.
Hey. Roy, yeah, I was just listening to this talk because I do pain management on a regular basis. One of the constraints, it's okay in private kind of healthcare. One of the constraints in UK will be to get CT for most of these procedures. And because of this ionizing radiation, now there is a trend towards doing more of these procedures using ultrasound, even without fluoroscopy. So that's where, I mean, the precision, of course, we cannot get with what you're doing. For example, for pancreatitis, I do fluoroscopic splanchnic nerve radiofrequency ablations just under X-ray control. And yeah, as you mentioned before, stellate ganglions, we do it under ultrasound. But I just wondered how many people can afford to get this treatment under CT guidance. So
Okay.
that's,
To answer that question, I do this procedure along with a pain physician. Okay. Now, I mean, she has taken away 90% of my practice just by tweaking drugs that she's being able to, control this pain. And I'm very happy about that. And she and I, we share one policy. We do not charge for cancer pain. For patients who are undergoing these procedures with cancers, we do it free of charge. And that is about the costing. And about the precision, definitely it is more precise than fluoroscopy. So when for example, your celiac plexus block, I showed you distended colon, which would have been missed by fluoroscopy, or even the proximity to some certain anatomies. When the kidneys are too close to the the vertebrae, you tend to miss it. Of course, with expertise, people do that. But here, you are visibly able to see the precision. You're sure that the patient was not injured. So that is one thing. And I started this before ultrasound came in a very big way for pain. So I started this around 2000, and so I was able to carry it out. And definitely, if ultrasound, if you guys can do it, without complications, and if you're able to get this precision, definitely ultrasound is what you should go for.
Roy.
Yep.
Roy.
See, who's that?
Usha. See, I think you remember sometime back, my nephew, he brought his wife, she had a compression fracture spine. You remember that? Some 4 years back. Actually, now she's suffering. She underwent second line chemotherapy. After that, she was okay. Now, for the past 2-3 months, due to compression, now she's finding it very difficult to walk, and there is also involvement of the lower thoracic vertebra again. So she underwent radiotherapy, and they've changed the chemotherapy. But again, she still comes. She actually all of you asked me about my birthday yesterday. We are all so depressed about her. That's why I didn't say anything, because we were all also first talking about Sai, then again other cancer patient. Didn't want to change all your moods. Can we help her something? Because
okay, how old is she, Usha?
She will be around 55, I think 55, 53.
Yeah, 55. And if she has 3 vertebrae which are fractured, 3 or 4 vertebrae, then we can address it by vertebroplasty. But if she has other pains, now then what will happen is we'll have to address it only. Other bones are also involved. Then I think the better option would be radiation only.
Yes, she underwent radiation now. Some 1 month back.
If she has just compression fractures, and if it's less than 4 in number, then we can treat it by vertebroplasty.
Yeah, my mother went underwent vertebroplasty. She was okay till the end, no problem.
Okay, so you can send me your X-rays. I can have a look.
Yeah, I'll see. I'll ask them. But I think she's having metastasis also. That is the main reason. And now actually they suggested radiation, and she underwent 10 sittings now. But after that, she has not improved much. She's
Where
only
is she? Is she in Chennai?
She was in Chennai, but at present she's in Tirupur only. Okay. I mean, taking her to Coimbatore to Chennai will be a very big problem.
I know that. See, that is the reason this should be made available in more places.
Yeah. So for pain, can you help her something? Can we do something? Because she's only
I can tell you, Usha, I can put you on to my pain physician. I'll connect you to her. Okay, 90% of the time she's able to take away pain just by tweaking the drugs.
Okay, Roy. Thank you very much.
Any more questions?
Right. Actually, you are doing these procedures. What is the risk of radiation to the patients, or how long the procedures take?
Okay. Jayanti, see, the number of CT cuts that we take with expert, as you get better in the procedure, it becomes significantly less. I don't have a numerical figure for you, but it will be as much as a CT thorax that we do.
Okay. Can you do repeated procedures on these patients, or you do only one?
Yes. I mean, see, if it's end stage cancer, now see that issue comes for patients who have just a disc prolapse.
Yeah.
Okay. Now, if a patient has got an end stage cancer and you're doing it for cancer pain, I think the risk of radiation is negated completely.
Yeah. Yeah, I understand. Yeah.
Why are you looking so angry, Srikanth?
Srikanth, unmute yourself. Unmute. Srikanth, you're muted. Srikanth, it must be early morning for him. He's just got out of bed.
No.
ஆங்கர்லாம் போறதுக்கு ஏதாவது இன்ஜெக்ஷன் இருந்தா சொல்லு ராய். ஆங்கர்லாம் போறதுக்கு இன்ஜெக்ஷன் இருந்தா சொல்லு.
Yeah, you were talking about anger போறதுக்கு injection.
Anger போறதுக்கா எனக்கும் அந்த ப்ராப்ளம்.
அது புவனேஸ்வரன் தான் கேட்கணும். ஏன்னா போன வாரம் சொல்லிட்டாரு anger management.
See, we do stellate ganglion blocks for angina.
Left stellate. 60 ml will do a lot of good.
Yes.
Flip will explain. Where is flip?
Single malt.
Where is flip?
Yeah, Srimati. Srimati's got a comment. Yeah.
No comment. Roy, that was a very lovely presentation.
Oh, thanks, Srimati. Means a lot to me.
And one more thing, Roy. See about multiple secondaries in the liver. You presented so many things. We could hardly, catch up with all of them, except the ones which are related to us in one way or the other.
That's the idea.
So, for multiple liver secondaries, multiple in the sense maybe they locate 4 or 5 spots.
Yeah.
Radio ablation, you think would be possible or feasible?
The largest should be less than 4 centimeters, and there should be less than 4 in number.
Okay. Thank you. I have my uncle who has CA prostate with secondary liver. So I was just thinking, he's in Bangalore. He's quite old. I'll just see how. He's undergone a whole battery of radio, chemo, everything now.
Yeah.
I think his
in secondary liver, Srimati, the thing is this: the oncologist should be very certain that he can do away with the circulating cancer cells by chemo. Okay. Otherwise, it's just a cosmetic thing, just going and burning, because next day there'll be more secondaries coming in. If the oncologist is very certain that he can do away with the circulating cancer cells, then we are justified in doing RFA for metastasis liver.
Okay. Thank you, Roy. Thank you. It was really nice.
மச்சா சிங்கிள் மால்ட் பத்தி ஏதோ பேசிட்டு இருந்தீங்க, நிறுத்திட்டீங்க அப்படியே.
What Chandra? How Sriram?
Chandra, unmute Chandra. Chandra, you're muted.
Flip என்ன ரொம்ப போர் அடிச்சிச்சோ.
Srikumar, I mean, he's going to watch the recording. He's gone back to bed and anything. Srikumar, any questions?
Single malt பத்தி அப்ப முதல்ல single malt பத்தி முதல்ல பேசிருக்கணும்.
Yeah.
Yeah.
Can you hear me?
Yes.
Yeah.
Okay.
Roy, really, I really missed a bit. Towards the end only I joined. The reason is today is not a holiday. Today is a working day, unfortunately, in this
understand.
part of the world. So I will catch up with the whole presentation. But from what I gather, it was quite groundbreaking and very nice. And I know that your field and your competence. So really missed it. Mainly the thing is for me, Sundays unfortunately are not off. Unless there's a recording, I'm not able to join fully. So fantastic, great job, keep it up, take care.
Yeah, I have recorded this and I will post it on our group.
Yeah.
Can you recognize the background?
Yes, I do. Yes, much. I do recognize the background. I thought of saying something, but it's not very appropriate now. But, I just want to add 2 points. I got a text from CMKR, and actually Roy showed me the text when I was in Chennai a couple of years back. And then also when Roy came to Miami in January, me and Murari were able to spend some time with him just before COVID started. So the text read, I'm amazed and impressed with what Roy is doing. And it was actually one of his relatives needed a biopsy of a lymph node that was very close to the aorta. And he was struggling to get that biopsy, but somehow he sent the patient to Roy, and Roy was able to take care of that. So, and then the other thing is my uncle was diagnosed with lung CA, and it needed to be biopsied. And the number of students Roy has taught, they're scattered all over the country. So this fellow, I say he's a kid because I think he's only in his mid-30s, runs the show in one of the big hospitals in Hyderabad. And Roy connected me to him, and I was really, really impressed with all the stuff that he's doing. So Roy, keep up the great job, much. I'm very proud of you.
Dhanapal, any question? Audio unmute பண்ணுங்க.
Actually, I think 2 years back or 3 years back, I was in Madurai, in Velamon Medical College. There, the 2 students presented about an innovative technology, as Roy was telling us. And I think it won one award. I was one of the chairpersons for that innovative workshop. So, thank you, Roy. I am very proud of you. Your
thank you so much.
Skills. Thank you.
Nuts?
Yeah, conclude.
Let's conclude. So I will send the recording to all the in the group. Roy, you're okay with that, Roy? To post you're okay to post the recording on our group?
Absolutely.
Yeah. Okay. That's good.
That's great.
Thank you, Suresh. Thank you, Nats.
Thank you, everybody.
Thank you, Roy.
All of you logging in means a lot to me. Thank you so much.
Okay, thank you.
I think we need to. Nuts will probably send details about the future next presentation whenever it is.
Yeah. Another 1 or 2 days I will post. No problem at all.
Yeah. Tyagarajan has got his hand up.
Yeah,
no.
Tata, just saying hi.
Oh, saying bye. Okay. Okay.
Bye, Tiago.
Right.
Modi.
Okay. Thank you, Roy. Thank you, Roy, for spending your precious time to us.
Bye.
And giving very good, excellent lecture. I really thank Roy for attending our Zoom meeting. With this, we'll conclude our meeting. We'll meet you in next Zoom meeting.
Bye, everyone.
Bye, everybody. Bye, everybody.
Thank you.
Okay.
Thank you all.
Thank you, Suresh, for giving your Zoom account for our meeting.
Thanks, Suresh.
You are always very friendly and helpful to conduct a Zoom meeting. Thank you.
Go and do it.
Thank you, Suresh.
Thanks. Bye.